Thanks so much for hopping on here. I'm just going to do a really super quick introduction, and then I'm going to pass this off to Keith, who you are more excited to hear from than me, I'm sure. I'm Holly with Keystone Trails Association, so super grateful that you are here and taking time to learn, which is a huge part of being a courteous hiker, is just understanding, how to help yourself, how to help other people, how to be mindful of the environment, which is all things you're going to learn about tonight. If you're unfamiliar with KTA, we do trail care around the state and orchestrate opportunities like this for hikers to learn new skills and be able to become better, happier, healthier hikers. If you like this webinar, we have a couple other ones coming up as well. They're all free. One's about how to hike the Appalachian Trail in Pennsylvania. We have one about trail maintenance, which you get to talk to volunteers and learn about what it's really like if you're thinking about trying it. And we also have one geared towards climate and hiking, and it's led by a somebody from the DCNR, which is going to be really cool. It's going to be a little bit of like learning and then a little bit of discussion amongst peers. Also, after going through this chat with Keith, if you're interested in doing like a full-blown certification course, we have one coming up in April. We're partnering with Terra Cross. I actually went through this course last year. It's phenomenal, highly recommended. It's just, it changes a lot for you, the way that you view how you're out there on a trail, but also just in life. And I would highly recommend taking that course for sure. What else did I have in here? Just another opportunity if you're looking to maybe get involved with KTA and want to do something that's like on your own. We have a 100-mile trail challenge, so you track your miles and you can get a sponsor, and at the end of it, you're able to make a donation to KTA. And it's just a really cool way to give back to trails. The money goes towards trail care, so it's super, super helpful for our mission to make sure that our hiking trails last for many generations to come. Another opportunity to meet our trail care crew. We're doing a little trail care roadshow to some breweries, and you get to meet some people from KTA and just learn more about our program and what we have coming up this year. This year is our 40th anniversary of doing trail care in Pennsylvania. So it's a super, super fun time to get involved and learn more about the program. And yeah, okay, that was it. Thanks for hanging tight through that with me. Keith Williams is here with us tonight from Lancaster Conservancy, and I have just had an absolute blast getting to know Keith over like the last year. I've had multiple interactions with him and helping to plan some events, and he's just a wealth of knowledge, and I'm honored that he was willing to spend some time with us tonight. He gave this presentation to a crew at our fall hike fest last year, and everything that I heard was fantastic and phenomenal. So you guys are in for a treat, I'm sure about that. Before I pass this off to Keith, just throughout his presentation, if you can please keep your mic muted. It's just courteous and it's very, very helpful to make sure that we can hear him. And if you have questions throughout the presentation, if you can just put them in the chat, I'll make sure that I'm watching that, because at the end, I'll try to get through as many as possible. We will be ending at 7, so we'll try to leave some time. I'm sure that he's mindful of that as well, just to leave a little bit of time for potential questions. And then just lastly, thanks for being amazing, for being here. So I'm going to stop sharing, and then Keith, whenever you're ready, sir, let's do this.
I'm ready to go.
Awesome.
All right. Can everybody see that okay? Everybody good? See it? Wonderful. So thanks, Holly, for that really beautiful intro. My name is Keith Williams, and I'm the Vice President for Education and Engagement at the Lancaster Conservancy. And we thoroughly enjoy working with KTA, both as an organization, they're great partners of the Conservancy, but also personally. I mean, the staff at KTA are just good, solid, fun people to be with, and I always enjoy my time with them. In addition to my job of getting people into the backcountry, either for engagement events or volunteer events with the Conservancy, I also work as a paramedic. I've been doing EMS for 45 years. I've been doing backcountry medicine for 20 of those 40 some years. I'm a wilderness EMT, and I work for a volunteer for a search and rescue team and a wildlands firefighter. And I'm also an instructor with Wilderness Medical Associates. In fact, I'm only a little bit jealous that Tara gets to teach the wilderness first aid class for KTA. Tara is a wonderful friend of mine. She's an amazing instructor. She's a mentor of mine. And I wanted that class in the worst way, but I've got an all-day commitment on April the 6th for my full-time job that I just can't get out of. Anyway, what I want to do tonight is really not teach a first aid class, because you need that 2-day class to be able to function. What this is really the why that 2-day class is important. And just to kind of get some background on exactly what does it mean to be wilderness context for starters, and why is it important that we understand how to function in that background, in that setting. And so just a little bit of background on who we are as Wilderness Medical Associates. These are our founders, Dr. David Johnson, Dr. Peter Goth. And these folks were MDs, they are, and also avid outdoors people. And they recognize that how we handle medical emergencies when we have easy access to all the machines that go bing, right? All the equipment that we need is different when we're in settings when we don't have all that equipment. And so they started Wilderness Medical Associates to help train people that spend a lot of time in the backcountry on how to respond to sick and injured people in austere environments, in environments that just don't have ready access to definitive care. And this is where it started, Hurricane Island in Maine, one of the outward bound centers. And so historically, Wilderness Medical Associates has had a pretty close association with outward bound. And this is where we kind of get into the decision of things. Let's see if there we go. What is wilderness context? So it's really anytime we have delayed access to definitive care. And so the answer to this question is, what is wilderness context? Is it depends, right? It totally depends. Where I'm sitting right now is a barn in Peckway, Pennsylvania. It's going to take EMS about 20 minutes to get here. I've got a paved road that goes right to the front door of this building, but they have about a 20-minute response time because it's a rural area. And so if I were to get stung by a wasp, and if I were to become anaphylactic, do I have 20 minutes to wait for EMS to get here? Probably not. So I would implement one of the wilderness protocols that we teach people on when they take a wilderness advanced first aid class or a wilderness first responder class, which is anaphylaxis, which includes instructing people how to inject other people with epinephrine and how to give them an antihistamine and how to give them a steroid, right? That's a specific wilderness context protocol. I would implement that protocol here and now, even though I have a paved road that goes right to the front door, because I'm not gonna make it 20 minutes if I become anaphylactic, right? On the other hand, if I dislocate my shoulder due to indirect force, and I'm in this same place, I am probably not going to implement the reduction of simple dislocations protocol. So we teach people how to reduce simple dislocations in a backcountry setting as a wilderness first responder. I'm probably not going to implement that one this time because I can wait 20 minutes for the paramedics to get here and splint that upright and go to the hospital that's about 45 minutes away. So it's a big it depends, right? But ultimately, it's delayed access to definitive care, and that could be because of a hostile environment. That hostility could be because of remoteness. It could be because of weather. It could be because of gunfire, right? Certainly combat fits the definition of wilderness context, austere environment. And so you've got access to limited equipment, right? As a paramedic, I would love to have my 12 lead EKG on me when I respond to the person who's having chest pains at the bottom of Pinnacle Hill during the KTA super hike. Did that happen this year? I can't lug in 25 pounds of equipment that really isn't going to give me any information that's going to help inform my evacuation decision. I can make those decisions without knowing if they're actually having a STEMI, ST elevation myocardial infarction, which is what that 12 lead EKG would tell me, right? So I have to learn how to operate in that environment with limited equipment. And so in the pre-hospital spectrum, right? Pre-hospital being before the care that we give people before they get to the ER. It spans starting in the really urban area, right? Where I work as a paramedic is really considered an urban environment. the hospital is right around the corner, essentially, right? So we have urban EMS, we have ambulances in the firehouse, in the ambulance squads that get toned out, and we have a relatively short amount of response time and relatively easy access to patients most times. There are exceptions to that, certainly, and there are times when I'm using wilderness protocols in that front country setting, in that urban setting, during disasters. For example, we get a hurricane that shuts down all the roads or most of the roads going to the hospital because the tree's down, then I can implement wilderness protocols, right? This middle column, rural EMS, ski patrol, SARS, search and rescue, outdoor ed and combat, that's where a lot of us who play in the outdoors live, right? That's typically kind of the settings. It's that gray zone where we're kind of sort of front country, but we're just far enough away from definitive care that these wilderness protocols really make a difference. And then on the far end of that spectrum, we get remote expeditions, disaster response, and offshore voyaging. You don't get much more remote than being on a sailboat in the middle of the ocean, right? And so just a couple of examples. Expedition medicine, going through the Grand Canyon certainly qualifies, right? I've been on some expeditions into Honduras where we're out for a month and we've got no access to medical care, or very, very limited access to medical care. And so, that medical kit that I'm going to carry and the amount of knowledge and the skills that I'm going to implement in that expedition are going to be a little bit more extensive than, say, for experiential education, which is where I spent most of my career, taking other people's children into remote settings, but not super, super remote, but far enough away from definitive care where if someone were to dislocate their shoulder due to indirect force, I'm going to want to reduce that right there and make that more of a comfortable, safer injury for that patient than having, that neurovascular bundle that goes through all those joints potentially impinged because of that humeral head floating around in that socket, right? And then we got search and rescue. So what happens a lot of times, which is really, really cool, is when I teach these classes, it's the first exposure that a lot of students have to any kind of emergency medicine, and they love it and they fall in love with it. In fact, that's how Tara got her start. So I don't want to steal her story because she's going to teach your class, but she started as a wilderness first responder because she was an instructor with Outward Bound. And she fell in love with that so much that she became a paramedic, and now she's a PA. So she went all the way to become a physician assistant. But again, the skills that we teach in these wilderness first aid classes are used by professionals in search and rescue settings. Certainly exploration and industry. Antarctica is a pretty remote place. And so that ship is a pretty remote place. Combat for sure, right? So the reason that we have limited access to equipment in this setting is because we've got hostile gunfire coming in. And so we do things a little bit differently when we're getting shot at compared to when we have more time on our hands that we can more fully treat people right where they lay. And then again, offshore voyaging, it doesn't get much more remote than that. Disaster medicine is pretty fascinating. And I'm part of a team that deploys after natural and human disasters in other countries. And, even disaster response here, I'm implementing wilderness protocols and when I can't make easy access to the hospital and my transport times are delayed because roads are flooded, trees are down, fill in the blank. Too much snow on the ground sometimes, although that hasn't happened for quite a while. And so what are these courses, right? And so the wilderness first aid class is the entry level course. Then you have the wilderness advanced first aid and then wilderness first responder, which is really the gold standard for folks that are taking other people into the backcountry. It's really an intro to the principles and practice of wilderness and rescue medicine. You do become trained and certified in wilderness protocols, right? So you get a card out of this, even out of the wilderness first aid class, you get a card. And there are certain wilderness protocols. There are 7 of them, in fact. When you take the woofer class, the wilderness first responder class, there are fewer protocols that we implement in the shorter courses like the WAFA and the WAFA. But those are really the important pieces of that, right? Those are the things that differentiate a wilderness first responder from a regular first responder, or wilderness first aid from regular first aid. Now, a lot of the content in all of these classes are certainly applicable in front country settings. It doesn't mean you have to be in backcountry in order to use these skills. You have to be in backcountry to use the wilderness protocol parts of this. But 70% of what we teach you is front country medicine. How do you respond to a cardiac arrest? How do you respond to a severe bleed? How do you respond to an unstable musculoskeletal injury? The differences are when you're in that austere environment, you're able to do a bit more aggressive, a bit more intensive treatments than what we can do in front country. It's not authorized to practice, an authorization to practice medicine. right? So you're not going to be prescribing anybody medication. You're not going to be drilling holes in people's skulls. You're going to be doing crikes, right? The thing here, you're not, no. It's not the only way to do anything either. And it's not all that you need. These courses are never all that you need. Again, I've been doing this for 40 some years. I'm constantly learning new stuff. And so I get to teach a wilderness advanced life support class, which I'm really excited about. So that's for practicing paramedics, nurses, and doctors. And I'm so stoked to go to Virginia and teach that with Tara in May, because I'm going to learn a whole lot of stuff from the students that are in that class. And just about every class that I teach, I learn a ton from. So any questions about what wilderness medicine is and why it's important before we move on to some of the core nuggets, core concepts?
I don't see any that anybody's put in the chat, but if
Okay.
anybody does have any, please remember that you can put them in the chat.
So let's jump into some of the core concepts that you'll experience as a participant in some of these classes. So let me pull up my second PowerPoint here. All right, everybody see that okay? So this is all about critical decision making, is what wilderness medicine is all about. And even more so than front country medicine, right? These decision points become really important in backcountry compared to front country. In front country, when I got a 10-minute ETA to a hospital, my evacuation decision is not all that risky. Do I go fast or do I go slow in the ambulance? That's about it. Do they get more diesel therapy or less diesel therapy? Do I go lights and sirens and not lights and sirens? That's the extent of my decision making. Whereas in backcountry, it's, do I hike out? Do I stay overnight? Do I call for a carry team? Do I ask for a helicopter? Right? That helicopter is extremely high risk. These are not safe aircraft. We crash them all the time. Just about every other week, there's an air medical crew that was killed in a helicopter crash. Somebody said there are 10,000 parts trying to shake themselves apart, is what is the definition of a helicopter. And so using critical thinking skills based on the concepts that we teach in these classes.
Hey, Keith, I'm sorry. We're seeing I wasn't sure if my screen was just lagging. I'm just seeing the slide for core discussions.
Oh, I wonder why that is. Hang on, let me
Sorry. I was like, maybe my internet's being weird.
Let me
Oh, I
see why.
see somebody else said the same thing. Okay.
How about now? Is that different now?
No.
Still the same. All right, let me try to unshare.
Okay.
And let's do this differently this time. Let's try share again. How about now?
So I see a lady in a scuba suit.
Okay, that's what we're looking for.
Okay. But
All right.
we can see like your notes and like the slide bar on the side. So.
How's that?
Amazing. Thank you.
All right. So right back where we were, we want to ferret out, is this serious or not serious? Is this a high risk or a low risk injury or illness? Which means, is it emergency or not emergency? Is the patient stable or unstable? All of that leads to our decision making of evacuation, of do we stay or do we go? And if we go, do we go fast? Right? And all of that has a higher significance in a backcountry setting because there's a lot more risk. Even right here, right? Like 10 minutes away, the Conestoga Trail is this beautiful trail. It's extremely remote and extremely rugged. And an hour ago, before it got dark, if I were to have an injury on that trail, I would think twice about sending a carry team in right now. We have snow on the way. We have rain on the way. It's really, really dark. I'm going to put 40 people at risk by going in and trying to fetch a hiker who has a twisted ankle. So I might have them ride the night out and go in the morning, right? Risk benefit decision. And my ability as a first aid provider or a wilderness first responder to assess serious or not serious, low risk, high risk, stable or unstable, helps me make those informed decisions that it might be we have to evacuate that patient right now, right? Perhaps they fell, they hit their head, and they've got a traumatic brain injury with signs of increasing intracranial pressure. That's a life threat. They can't wait until morning. Perhaps they fell, and because I did really good first aid care and I did a really good patient assessment, I can rule those things out. I can rule out a traumatic brain injury, which automatically rules out increasing intracranial pressure. And so really all I'm dealing with is a tweaked ankle. all I have to worry about is keeping them thermoregulated through the night. I'm much more inclined to have them stay out in the field overnight and have the team come and meet me in the morning, right? So the risk benefit ratio is really important. So we want to avoid high risk solutions to low risk problems. And so there's the helicopter. You're going to see helicopter slides, right? Because again, extremely dangerous platforms. I work with helicopters all the time. In fact, I just called for a patient to get medevac from her. She fell in her kitchen, hit her head, was on a blood thinner, and was unresponsive. That equals a pretty significant traumatic brain injury, which means I want a helicopter for her, right? So urban setting, I called for a helicopter. In this picture, this was a boat that was taken on water. And I think they plucked, I don't know, 10 or 20 souls off that vessel and put them in the helicopter. I think it was 10. Right after that picture was taken, the helicopter crashed and killed everybody on board. That boat stayed floating 24 hours later. Right? Now, I'm not going to Monday morning quarterback the decision making that crew made because I wasn't there. I don't know all the variables that they had to assess. But that's an example of a high risk solution to a relatively low risk problem. Right? We want to avoid those. And again, it comes down to being a really good first aid provider. That's how those decisions are made. That's the information, that's the data that we need in order to make those difficult decisions. All right, probability and consequence. We are no more likely to get hurt in the backcountry than we are in the front country. The problem is when we get hurt in the backcountry, the consequence of that injury or the consequence of that illness is much greater because we have to worry about a whole bunch of other variables in backcountry that we don't have to worry about in front country. Things like thermoregulation, right? So let's say I went and I tweaked my ankle to the point where it's an unstable musculoskeletal injury. Unstable being I can't bear weight. I can't walk on that. And I do it right here on the back steps of the barn. Not that big of a deal. I'm inside. It's warm in here. It's not raining on me. I do the same thing 10 minutes away on the Conestoga Trail, about a mile from the trailhead. All of a sudden, that becomes the consequence of that same injury becomes much greater because if I'm out there, what I'm wearing tonight, I am probably not going to survive the night without becoming hypothermic, right? So the consequences of those injuries and illnesses in backcountry are much greater, but the probability is about the same. We always want to start generic to specific, right? So when people become sick or injured in the backcountry, it could be because of 3 different mechanisms of illness or injury. It could be a medical problem. Let's say that their blood sugar got low. It could be a trauma. They tripped and they fell and they hit their head. It could be environmental, either too hot or too cold. It could be a combination of any of those 3. It could be all 3. It could be that they had low blood sugar, which resulted in them stumbling and falling and hitting their head. And now they've been laying on the trail in 20-degree weather with snow for 3 hours, and so they're hypothermic. So if I went in thinking this was only a trauma, I'm missing 2 other things that are making this patient sick. If I'm going in thinking it's only a low blood sugar, I'm missing 2 other things that are making this patient sick, right? So cast that really wide net when you're approaching a situation. And a practical application of this is diagnostic distinctions, right? Learning how to ferret out respiratory distress, somebody having a hard time breathing, from respiratory failure, somebody not effectively breathing anymore. Not respiratory arrest when they're not breathing at all, but respiratory failure is they're not breathing adequately to support life. They're still trying to breathe. Mild hypothermia versus severe hypothermia. This is really significant because this is going to change my decision making on fast or slow. We already talked about this a little bit. Traumatic brain injury versus non-traumatic brain injury, right? If I have a traumatic brain injury, I am worried about that patient. I might not be doing an emergency evacuation on them, but I'm worried about it because I'm worried about an anticipated problem of increasing intracranial pressure, right? Damaged tissue swells. When that brain swells, that pressure can't go anywhere because it's inside the cranium. And so that winds up creating increasing intracranial pressure, which means if that continues, the brain herniates and it gets pushed out the magnum foramen, which is the only opening we have in the base of our skull, and the patient dies. We have to catch the early show on that. So if I have somebody that has a TBI, a traumatic brain injury, and we teach you specifically what those signs and symptoms are of a traumatic brain injury, so you can definitively say, yes, the patient has a traumatic brain injury. And if they have that, I am worried about, I have an anticipated problem of increasing intracranial pressure. And if I see persistent vomiting, and if the patient complains of a severe headache, those are both early signs of increasing intracranial pressure. I'm calling for the helicopter. I can make that high risk transportation decision because this is a high risk problem. All right. Fracture versus sprain, I can't tell that. No idea. I can tell if it's stable or unstable, right? I can't tell you if it's appendicitis versus diverticulitis when I got belly pain, but I can tell you if I have pinpoint belly pain accompanied with fever, that's a red flag and that patient needs to go out, right? I can't tell you if they've got neurovirus or rotavirus, but I can tell you that if they're vomiting and I can't stop that leak, that fluid leak, they are probably going to become hypovolemic, which means they're going to be in compensated volume shock. And I need to manage that because the anticipated problem from compensated volume shock is decompensated volume shock. When somebody comes unresponsive because there's just not enough fluid in the system to keep the brain bathed in oxygen and sugars. And ideal to real. We talked a little bit about this when we were doing the medical standby for I keep calling it the super hike. The name changed, the trail challenge, which I love doing, by the way. That's a lot of fun. I used to love running it. I want to run it again. Maybe I won't do medical this year. Maybe I'll run it instead. Although I get a pretty good workout doing medical on it.
I'm sure you do.
In the ideal world, I would have that Life Pack 15 right there with that patient that's having chest pains at the bottom of Pinnacle Hill. So I could diagnose an ST elevation myocardial infarction, a heart attack. My real world, though, is I don't have that equipment, right? So I have to make diagnostic decisions based on a good patient assessment, and I have to make evacuation decisions based on those diagnoses. So ideal to real. Focus on the important. I tell this. I'm gonna ruin my own future teaching with KTA for these classes now. Classic example is I responded to an assault, and I roll up, and there's this guy who's obviously agitated because he just got beat up, and he got his foot run over by a truck. A pickup truck ran his foot over, and he's yelling at me, "My foot, my foot, my foot! Fix my foot!" I'm like, "All right, hang on a minute, dude. So we're going to teach you how to do primary assessments, right? In a primary assessment, you're looking for critical life threats that you have to fix right now or the patient's going to die. And one of those things is you're looking for severe bleeding. And so that involves a blood sweep, which means you get under layers and you check to see if this patient's bleeding from the core area. And I'm doing this, and this guy's really cursing me out. And he's like, "What the hell's your problem? I told you it's my foot. There's nothing wrong with me." I checked his back. He's got 3 stabs in his back. And 2 of them are bubbling, which means the lungs are involved. So he got a helicopter ride. So if I focused on the urgent, but not the important on him, the urgent was his foot, he probably would have died. But because I relied on my training and focused on the important of doing that blood sweep, doing that primary assessment thoroughly, we were able to catch those life threats and get them on a helicopter and get full recovery. So we will teach you how to use SOAP notes, subjective, objective assessment, and problem list, right? So the A is the assessment, and that's a listing of existing environmental problems and threats, existing medical problems, and then anticipated problem and threats. And that P is your plan. Based on your assessment, based on your problem list, every problem and every anticipated problem needs to have a plan for it. What's your risk-benefit analysis? What's your action to prevent anticipated problems? So on a night like tonight, if I get called out tonight for a lost hiker, or if I get called out tonight for a person falling on the Conestoga Trail, on my anticipated problem list is going to be hypothermia. It's going to be cold challenge and hypothermia. I need to be ready to act to prevent that. So 50% of the stuff that I carry in my pack right now is to prevent hypothermia, to prevent cold challenge. And then finally, medicine is dynamic. And so one of the reasons why I really enjoy teaching for Wilderness Medical Associates is because the curriculum that we teach is based on the latest and greatest science. We've got an amazing medical director. We've got an incredible president, and they depend on the most recent, thoroughly vetted medical science to base our curriculum and our protocols on. So it's not just hearsay. The stuff that I'm teaching for Wilderness Medical Associates, the stuff I was teaching for WMA 15 years ago, Street EMS is just now catching up to. That's how advanced that curriculum was. I teach the same patient assessment system to paramedic students that I teach to wilderness first aid students. So it's the same patient assessment system. So what we know is good science and solid experience, and that's the foundation of WMA's curriculum. I'm in awe of other instructors and the life experience that they bring to the table. I mean, you want to talk about backcountry medical badasses. There are instructors that skied down Rainier with their own broken back with a splint that they created, who intubated patients while they were rappelling down a cliff face. Just crazy, crazy experience coupled with really good science. And that's the foundation of what we teach and how we teach it. Now, there are gaps in that, right? There's gaps in that knowledge. And so we have incomplete science, we have tangential experience. And so sometimes in our real world setting, go back to that concept of ideal to real, we certainly rely on that good science as much as we possibly can. We rely on our wilderness protocols, but every patient doesn't fit into that box. And so sometimes we have to rely on incomplete science and tangential experience. And then sometimes you do what kind of just makes sense. So that's the first half of medicine is dynamic. The other half is patients change. The medicine that you're seeing before you, your patient is not going to be static. They're dynamic. They're going to change with time. The scene is going to change with time. So the first thing you do before you do anything is do nothing, right? You need to make sure that scene is safe for you, for your partner, for anybody else, and lastly, for that patient. Those scenes change. It's not like you do your scene size up one time and check that box and move on. You're constantly going back and revisiting that because scenes are going to change, weather's going to change, people are going to change, right? So just be ready to improvise, adapt, and keep an open mind because stuff is not going to be static. So those are the general principles that we get across in different degrees and different depths, depending on the class that you take, whether you take wilderness first aid class or a wilderness first responder class, 2-day class, 7-day class. These are the principles that you get to. We get into a whole lot more detail on treatment when you take the longer class, obviously, compared to the shorter class. But man, that short class, that 2-day is amazing. How far people get in a relatively short amount of time in their confidence and their capability and competence to deal with very difficult, serious medical emergency situations in the backcountry, just in terms of their decision-making capabilities. And we teach you how to deal with all the major life threats, breathing problems, neurosystem problems, cardiac system problems. And then we get into some of the other stuff, the musculoskeletal. Any questions at all?
Yeah, I just wanted to, well, I wanted to second that, and then I did have a question to pose to you. Something that you and I had talked about before that was incredibly enlightening to me. But just a second, what Keith was saying as far as learning in that course, beyond being able to help other people, it also helps you be a lot more mindful about your own well-being while you're hiking and just like kind of picking up on things of what seemingly would just like even just like being more cautious and aware of your hydration and like what can start to happen if you're not drinking enough water and just like being aware of those signs, or like you has talked a lot about hypothermia and just being monitoring your body temperature and how to prepare for that and what signs to look out for. And it does change a lot of perspective. Speaking of changing perspective, Keith, something that you and I had chatted about, I'm not sure if you remember the discussion we had when we did that little video interview, and you talked a little bit in that video interview about the like environmental impact of wilderness first aid.
Oh yeah, for sure.
And that when you talked about that, it was like, oh my gosh, I never even thought about that, but that makes so much sense. Would you mind just touching on that for a minute or two?
Yeah, so a lot of times the standard response to go get somebody out of the woods is a chainsaw and a UTV. Let's cut a path and get a wheeled mechanical vehicle to them and haul them out. When in reality, if we do just a good patient assessment, we can often walk people out. In fact, I had a woman that during the KTA super hike was having chest pains at the bottom of Pinnacle Hill. They stopped with rest. That's called stable angina. We can hike that out. And that's exactly what we did. We took a lower stress route than going up Pinnacle Hill, but we were able to get out and get her to medical care without calling for a UTV to come and get them. So sometimes that's just what you're going to have to do. Certainly, if I had somebody with a spinal injury, and we do teach how to do a focused spine exam to rule in or rule out definitively spinal injury. And if we have somebody that we do a focused spine exam on and they are spine injured, they're going to be fully immobilized, and that's going to be a carry. Carries are hard and they're dangerous. And so sometimes it is going to be a UTV going right to that patient's side. But in a lot of cases, we don't need that, and it's just better for the environment. And that's part of, it's really a leave no trace thing, being prepared to go where you're going and being ready to take care of yourself in that setting. And then with first responders coming in, just having them trained in backcountry medicine and authorized to use those wilderness protocols. Just because you have the training in the wilderness protocol doesn't mean that you can use it. You have to be authorized by your medical director to do that. As a first responder, saves a whole lot of wear and tear on people and on nature. So I see some questions on hyponatremia, which is a great question. So I was talking about hypothermia, right? Low body core temp. Hyponatremia is diluted salts. And we can figure that out in the field based on getting a good sample history, right? And in fact, I had a hyponatremic patient during the KTA super hike. I love this event. This is all kinds of good experiences for us. So I get this woman and she is totally gassed. She's just exhausted. Hyponatremia appears as heat exhaustion. And so that's the negative feedback loop, right? It's a hotter environment. People are starting to feel a little woozy, so they drink more water. And they're not eating when they're drinking. So they're not replacing their electrolytes, they're just replacing fluids. And so they start feeling a little bit more woozy. So it's got to be heat exhaustion, right? Heat exhaustion is really just a form of dehydration, which is a form of compensated volume shock. So let's drink more water without replacing the electrolytes. And I feel worse, so let's drink more water without replacing the electrolytes, right? So I get to this woman at the bottom of Pinnacle Hill, once again, completely gassed. She's got nothing left. And when I do my sample history, the E, SAMPLE, the E is last ins and outs. Well, ma'am, how much water have you had to drink? Oh, about 3-4 liters. It's noon. So 3 or 4 liters since 8 o'clock this morning. And how much have you had to eat? Nothing. So she had no food, 3 to 4 liters in the system. She's hyponatremic. So we didn't fluid restrict her. We gave her a little bit of water to drink in addition to some granola after checking allergies, right? Don't give anybody anything to eat before you check an allergy. Been there, done that. Not me, seen it though. Had the epinephrine ready to go. And we were able to get her energy level back up to where we could hike her out, right? So it's really about getting that good sample history that you can ferret out. And then obviously she needs to go to the hospital for follow-up and get some blood work to figure out exactly what her electrolyte levels are, and probably need some IV therapy to completely resolve that. But we were able to resolve that enough so that we could implement a very low risk evacuation.
Does anybody else have any questions for Keith? Again, like I said, if this is interesting to you, which I don't know how it can't be, because I find it incredibly fascinating, but if you are interested, like I said, in April, oh wait. Does the spinal assessing happen in WFA or in WFR training?
Yeah, it does not. It happens at Wilderness Advanced First Aid and up. So WFA is just too short of a course to get that focused spine exam protocol in. So it's the longer classes where we do the spine exam. Now we do teach you in Wilderness First Aid to assume a spinal mechanism of injury or not, right? So that's a judgment call. So you assume spinal mechanism of injury based on the trauma, the force that was applied, how that force was applied. If you assume that spinal mechanism, you assume a spinal injury. And then as part of your treatment plan, you do the focused spine assessment, the focused spine exam, to either definitively rule that in or rule it out. Does that make sense?
Yes.
Yes, thank
Great.
you.
I see another question about Good Samaritan regulations. So for Good Sam to happen, if you are acting as a volunteer, right? It's not you have no duty to act. It's not your job description. So as a volunteer paramedic, it's in my job description, so I'm not covered under Good Sam. I've got a duty to act, right? If you have no duty to act and you're acting within your level of training and you're acting in the best interest of the patient, the Good Samaritan Act covers you, right? So for example, the EpiPens, which is a wilderness first aid protocol, right? If you administer an EpiPen to somebody who's in anaphylaxis, you're covered. Anything that you're trained to do, you're staying within your level of training. And again, you don't have a duty to act. You're covered under Good Sam, as long as you're acting as another competent care provider would. Nope, no prior medical experience required for any of those courses, in fact. So wilderness first aid, wilderness advanced first aid, or wilderness first responder, we teach that from the perspective of folks have zero background.
Mm.
And we get them from no training at all. And in fact, at the woofer level, most of those wilderness first responders are doing more at the end of that 7-day class than EMT students are at the end of 6 months of training because of the wilderness protocols. Oh, yeah. Hey, good question, Steph. Yes, there are. And those are listed on the website. So basically, you have to be able to bend down and kneel in order to do CPR, right? So there's a lot of time on the ground where patients are on the ground. You have to be able to get to the ground level to be able to do your assessments. I think in the physical job description that's listed on the WMA website, there's also something about carrying 40 pounds. For the WFA class, that's a lot less necessary because we're not doing litter carries in the wilderness first aid class, right? When you get to woofer, wilderness first responder, when we start teaching people how to package people into a rescue basket, a litter, and do those carries, then it becomes a little bit more important that you're able to carry 40 pounds. You're not carrying it by yourself. You're part of a team of 6 people that are doing those carries, 3 people on each side of the litter. But you can find those on the WMA website, what those physical requirements are.
Does anybody else have any questions? Like I said, if you go to KTA's website, kta-hike.org, we are offering, like I said, the certification course that Keith has referenced in April with Tara, and she's a phenomenal instructor. And oh, here's another question.
Yeah, so just to echo, let's finish your thought for a minute. Can I finish it for you?
Oh, sure, yeah. If you want to do a plug.
I can't say enough about Tara. She
I
is
know.
awesome. I'm so jealous I don't get to teach that class because I love KTA so much. But I tell you what, you really got a world-class instructor for that 2-day.
Yeah.
And keep an eye on the Conservancy webpage because we'll be offering these periodically too. In fact, some of the KTA folks went through one of our Wilderness Advanced First Aid classes last year. Well, we got a couple of great ones. Is it best to start with WFA or woofer? It really depends on what you want to do. I recommend the woofer class because that's kind of the standard of care. And so if you're only worried about yourself and taking care of yourself, the WFA is probably okay. If you're going to be out as part of a group, or certainly if you're a leader, if you're going to be leading a group, then I strongly recommend the woofer. In order to research, so your WFA certification is only going to be good for 3 years, and you have to recertify. And basically, you have to take the whole WFA class again. There's not a shorter version of that. So you're going to sit through the same 2 days of WFA. If you take the WAFA, the 4-day, that's another recert after 3 years. That's a 3-day recert, or you can do a 4-day bridge class to woofer. So that's what a lot of our folks do, is we train them to a WAFA standard, our folks being Conservancy, our volunteers. We train them to a WAFA standard, and then when it's time for them to recert, our plan right now is to have them go through the 4-day upgrade class to Wilderness First Responder. There is a 5-day Wilderness First Responder option that's hybrid. So you spend about 30 or 40 hours pre-course doing virtual textbook work. And then you do all your psychomotor work, your physical work, your practical work in 5 days of face-to-face instruction. So that's another option for, 7 days might be a little bit too much time to be face-to-face. So the recommendation of taking the WFA or the WFR It's really your choice and what you intend to do with it. But know that the WFA is only going to be good for 3 years, and you got to take it over again. The woofer is only good for 3 years, but then that's a 3-day recert on a 7-day class. What would you keep in a pack? I keep a pocket mask, and I keep 2 tourniquets, and I keep medical gloves in my pack all the time. And that's what I think is the absolute bare minimum for folks, because that's going to stop immediate life threats, and it's going to keep you safe in the process of fixing immediate life threats. But you got to be trained how to use those. So carrying those in your pack without a WFA class, kind of pointless. Other than that, I would keep Band-Aids and stuff for blisters, right? Yes, tourniquets are taught in wilderness first aid, absolutely, along with pressure dressings. And so that's part of that primary assessment, is finding those critical life threats, which is a serious bleed, and we teach you how to fix those.
That was probably one of the most fun, the whole thing was super fun, but that was probably one of the most fun segments, is like learning how to do innovative like splints and tourniquets and like how to just do all that kind of stuff. It was super interesting. Like I never thought about some of the ways to utilize anything that's in your backpack to
Yeah.
help somebody. It's super interesting.
One of the things we teach is practice with what you carry, right? So if
Mhm.
you're not going to carry a SAM splint, which is aluminized foam basically, then learn how to make a split out of the stuff that you're going to carry. The tourniquets, we really recommend you carry commercially available tourniquets, because fashioning one out of a cravat with a pen to get it tight takes forever, and the patient's probably going to bleed out before you get it on. And they typically don't get tight enough to really stop the bleed. And the commercial tourniquets weigh nothing, and they're really inexpensive.
You also get to learn how to pack somebody like a burrito for hypothermia, and that's also incredibly fun. So that's a perk. Any other questions for Keith? Well, I hope that everybody at least like understands more. Again, this was a like what is wilderness first aid discussion, and what Keith shared was incredibly valuable for understanding that, of what is the difference between this versus like a regular just first aid. I think it helps get the context of the importance of like how long do you actually have and what's your environment and how that impacts the choices that you make. Like that's a big portion of it. And um super grateful for all of you spending some time with us this evening. And like I think if nobody saw it in the chat, or if you did see it in the chat, just to reiterate, I will be sending the recording of this probably tomorrow, but please be patient. If I don't get it tomorrow, it'll be the next day, I promise. And I'll also include some links to the Lancaster Conservancy and to KTA, and make sure that you support Keith's work in the Lancaster area. If you're unfamiliar with the Lancaster Conservancy, my goodness gracious, I hope that you're able to take some time and go visit some of their preserves and get involved with their events, because they have wildly amazing things going on. Keith, do you have anything coming up that you want to give a little shout out about while they're
We've
here?
got, our spring season's just about to start, and we've got this one preserve called Shanks Ferry that is just a world-renowned wildflower preserve, and so come and see that. The peak of the bloom is usually about the second week of April,
Hmm.
and it's just incredibly beautiful. So come on out. We've got about 40 miles of trail on our preserves, and so just come on out and go hiking.
Yeah.
Take a look at our events page. That has all of our stuff on it.
Yeah, there's so much going on there all the time. It's insane. So cool. Well, thank you guys again. This was super fun. I hope you learned some stuff. And yeah, be sure to check out Lancaster Conservancy, and we look forward to seeing you guys again for something with KTA.
Thanks, everybody.
Thank you, everyone. Have a good night.